Here we are showing a case of lower pole renal stone, stented previously, planned for RIRS, but we switched to PCNL intraoperatively. Why? The patient is a 61-year male with poorly controlled diabetes with a 15 mm stone in the lower pole. Stent was placed 2 weeks back for pyelonephritis and he was planned for RIRS. But when we did cystoscopy, there were a lot of pus in the bladder. This is the CT picture showing the stone in the lower pole, and these are the axial cuts of the same. So when we did cystoscopy for planning stent removal, lot of pus flakes were there in the bladder and around 150 ml of purulent fluid was drained. So even after giving multiple bladder washes and clearing up the bladder, after that also we encountered lot of pus flakes which were studded all over the stent, all across the entire length of the stent. So much pus flakes were there on the stent. So at this moment, we became skeptical whether we could do RIRS successfully or not, even with suction incorporation, for the fear of sepsis. We removed the stent and did initial ureteroscopy. So when we did ureteroscopy, the ureter was accommodable and subsequently an access sheath was placed and flexible ureteroscopy was done. When we went inside the kidney, a lot of pus flakes were there in all the calyces and some necrotic material was adherent to the wall of the infundibulum in multiple places, and it was not a single big stone, it was rather multiple small stones with a lot of pus flakes around. So on seeing this inflamed kidney with a lot of pus, we thought PCNL was a better option because even with suction incorporated access sheath or direct in-scope suction, sometimes all the pus flakes may not be cleared, because when we attempt to do suction in such an inflamed kidney, which is a non-dilated inflamed kidney, it might start bleeding, and all the necrotic material, if we try to scrape off, it might start bleeding, obscure the vision. Subsequently, the stone fragments might get missed and ultimately patient might land up in sepsis. So that was the reason we switched over to PCNL even though the patient was stented previously. So using flexible scope, the contrast was injected, RGP was done, multiple filling defects were there in this non-dilated kidney. The lower calyx was aimed at, but quickly the contrast was disappearing, it was draining because of the gravity, and therefore we used flexible scope again to inject contrast in the desired lower calyx, and puncture was done under fluoroscopic guidance and urine drained from the needle, and subsequently we went ahead with dilatation. Guide wire was passed into the ureter and a serial dilatation was done, and 18 French Amplats sheath was used, and once we went inside, all the pus in the kidney was sucked through the Amplats sheath using a suction catheter. And once this was done, the kidney looked clean with all the pus drained and the multiple small stones were removed using nephroscope. And once these fragments were cleared, the other adjacent calyces also we inspected as much as possible with a nephroscope, and again suction was done in order to reduce the intrarenal pressure and also to clear the pus flakes. Then finally we also did flexible ureteroscopy to the adjacent calyces which were at an acute angle with the nephroscope, and in one of the parallel calyces some stone fragments were seen. Some of them came out by suction into the Amplat sheath, and for some residual fragments we did laser lithotripsy. All those calyces which were initially filled with that much pus were cleared by now completely, and we could complete the stone also clearance using laser lithotripsy. So in this way, the patient did not land up in urosepsis. Ultimately, PCNL was useful in this patient because postoperatively it was uneventful and the patient was discharged on the second postoperative day. We removed the nephrostomy on the second postoperative day and the patient was discharged. So therefore, in such an inflamed kidney with lot of pus flakes and papillary necrosis, all the pus flakes which were adherent to the wall of the infundibulum, in such a case, doing RIRS might have been difficult. The patient might have landed up in urosepsis because of the lot of pus flakes, infection, increase in the intrarenal pressure, and chances of bleeding, and the clot formation which might obscure the vision. So all these disadvantages were overcome with the help of PCNL in this case. Thank you.